Okay guys, welcome back. We're gonna do a video today where I wanna show you some different knots that we use in the operating room for tying. I wanna show you how to load a knife blade onto a knife handle. And I'm gonna show you, commonly people will ask me how to hold the instrument, or a lot of times we'll see med students just not really know how to hold an instrument because no one's really taught them how to do that. So I'm gonna show you how to do that real quick. And then we're gonna run through just a few simple sutures that I use and how to take them out, because sometimes people don't know how to take them out, and there are some nuances to taking out sutures that if you don't do it right, you can leave some suture behind. And if it's a permanent suture, they may come back months later saying, hey, I feel this thing behind my ear from my facelift, and lo and behold, I go back there and I'm like, my assistant, left a piece of Prolene suture, which is permanent back there. So I'm gonna show you how to take those out so that doesn't happen. So the first thing I'm gonna do today is show you how to load a knife handle. This is a knife handle. I prefer rounded handles. And the reason I like the rounded knife handles because when I'm cutting in plastic surgery, like if I'm cutting around the areola, I can rotate and pivot the knife when the blade is on there, and I like that. So you can't really do that as well with just a flat scalpel blade, handle. So this blade that I'm gonna show you here, it happens to be a 10 blade, a number 10 blade. Let me hold that up so you can see that. It's a bigger blade, but blades come in all shapes and sizes, and we'll cover that in a different video. But if you see here, if you look up close there are little grooves in the handle. And while it seems unsafe for me to hold a very sharp blade in my hand, it's actually the easiest way to load a knife handle. Some people will load it this way with my hands like I'm going to show you. Other people will take their needle driver and they will grasp the end of the blade and they'll put it on that way. And sometimes I don't like this big lever here because occasionally the blade can fumble and move and then you can cut yourself. I like to put the blade on with my hands because I have direct control of the blade and I know that I'm not going to cut myself. Now there's a certain way that this goes on. It's basically made dummy proof. There's an angled cut at the end of this blade that matches the angle on the knife handle to know that those slide together, so I know that that way would be backwards. So when you go to load it, you basically take the grooves of the knife handle itself and you get them into the grooves of the actual blade, and then it's gonna slide and click. So that's how you put a blade on. You should always, as a rule of thumb, sew towards yourself. It's very difficult for me to shoot a video where I'm shooting this way. So I'm gonna actually make a cut in this board that goes right to left so that I'm sewing towards myself. So we're gonna cut through just one layer of this pad. There's like 6 pads down here. So I'm gonna go ahead, and this knife is pretty darn sharp, and we're gonna make a couple cuts to get all the way through. I've used this knife for some other things. This isn't a fresh knife. So we're gonna make our way through this pad. And you can see here that I'm revealing the other pad beneath it. So that's just a simple cut. I will reflect this with my forceps so you can see, just made a cut in this rubber pad, and underneath there's some other rubber pads. And so we're gonna do our sutures today based on that cut right there. Before we start sewing, let me show you, we're not gonna need our knife anymore. Let me show you the way to hold an instrument. This is a 6-inch needle driver. There are several ways to hold it that suffice and are correct. The one rule of thumb that I always learned in surgery was 3 points of fixation on an instrument gives you the best neurological feedback control. There's so many nerve endings in the tip of your finger for tactile sensation that feed back to your brain that there's a certain way to hold it that it makes you more efficient, and a certain way not to hold it. One of the wrong ways that I'll commonly see medical students hold it is by using their pointer finger and their thumb. That is not the correct way to hold an instrument. You have zero control over that instrument. I've also seen some people put their middle finger, and again, that's a little bit more appropriate, but not as appropriate. And then you can see my pointer finger then is kind of around the instrument, which doesn't give me any tactile sensation through that finger. The truly correct way to hold a needle driver is the ring finger and the thumb go into each eye of the needle driver, and the index finger goes down the shaft of the instrument. And the reason for that is that finger right there has so much neural feedback when you're suturing that you can feel from this finger up to your brain that it allows you for better dexterity. Wrapping it around the instrument is the wrong way to do it. You want your finger on the shaft of the instrument when you suture. An alternative way that you'll see some people hold an instrument is they'll palm it. Palming it also does give you 3 points of fixation. There's the thenar and the hypothenar eminence of the hand, the thumb versus the pinky side. You can place each part of each eye of the needle driver can go in one, and then a finger down on the shaft of the instrument. And with that, you can actually open and close the instrument with the thenar eminence of your hand. And that in and of itself, I sew this way a lot because I'm used to it. I'll do that and that's appropriate, okay? But I also will hold it like this a lot. The second thing I want to show you is, this is my Adson forceps. There's Adsons with teeth and without teeth, and this has with teeth. And so a lot of people will erroneously hold a pickup this way to go grab the tissue, and that's very awkward and not the way to sew. You want to hold it like a pencil. And that's literally all you do, is you hold it like a pencil. So I've got ring finger and thumb, index finger on the shaft of the instrument. I'm holding this like a pencil. I'm ready to go. I can grab the tissue, control the needle, drive it, turn my wrist to pick it up and do what I need to do. Another thing that I see a lot of people struggle with when they go to pick up the needle, and I'll show you, is pronation of the arm versus supination of the arm. So when you go to throw a needle through, you don't want to supinate to try to grab the needle and pull it out with a curve, because that's super awkward. You'll throw the needle and then you will pronate to grab the needle and roll it out of the tissue. Because when you drag the heel of the needle through the tissue, it can damage the tissue. So those are some basic things. So we're gonna start here. I've got a vicryl suture. I'm not picking any particular suture today. I'm gonna teach you about absorbable versus non-absorbable and braided versus non-braided in another video. But this is a vicryl. It is a 3.0 vicryl, or 3-0 vicryl, which signifies the size of the suture. They're thicker the lower the number. So a 2 is thicker than a 3. A 6-0 is like sewing with your hair, or not even really, 10-0 is. But so this is a 3-0 vicryl, and it's on what's called a PS2 needle, which stands for a plastic surgery 2 needle. This happens to be a cutter needle versus a taper tip. All that stuff we're gonna go over another time, but this is a vicryl. So I'm gonna show you when you unpackage a suture, it's essentially sterile, and I'm not sterile now, but this would be sterile when they pass this off to the field. It comes in this aluminum foil container. The needle is always loaded into the plastic bin that the suture is sitting in. And the way that you grab a needle, I'm gonna show you that. I'm gonna show you two different things. One, there's just grabbing it at the heel. I curve the needle out and you just pull it out like that, okay? So you pull the suture straight out. Now when it comes to actually loading a needle, okay, I think this is really important, and I wanna show you the proper way to load a needle. Now this vicryl is white. It comes in dyed, purple as well. So how do you load a needle and where do you load a needle? So generally speaking, you don't want to grab a needle with your fingers, because you have to assume that every patient has a disease, HIV or hepatitis. If you go to grab a needle, you can stick yourself. So you should only be handling a needle with forceps or with a needle driver. So I'm going to grab this needle at the tip. And if you look at the curvature of a needle and we break this up into fourths, you want to load the needle either, probably sometimes you'll put it at the halfway point, but the most common place is 3/4 of the way. So slightly back, not at the heel, because if you're at the heel, it's very hard to control. If you're too far forward on the needle, it's difficult to throw the needle and to get it through the tissue. So just about 3/4 at the back end of the needle is where you want to load it. So that's the proper place to load a needle into your needle driver. Once that's loaded, you're ready to go. My index is on the instrument, ring and thumb. I got my forceps held properly. This is our braided suture. It's white. That's why we're using a chocolate background so you can see it. Okay, so let's just show you a basic, simple interrupted stitch. This is where we have a cut and we just want to bring the two edges together. So I will use the technique where I put my fingers in it. You can see I naturally went to palming it, which actually is what I do. So I'm gonna do that. So I palm the instrument. What I'm going to do is I'm going to pronate so that the needle goes in at 90 degrees to the tissue. These are things I'm getting very particular about. I'm gonna actually just do this stitch, but when you're doing it, you wanna come in at 90 degrees. That's the proper way versus just coming in like that. So I'm gonna show you just a simple interrupted stitch. I'm gonna take a bite, and then I'm going to rotate through and grab it with my instrument and pull it out. That's one way to do it. Load it where it's supposed to load, pull the needle all the way, or pull the suture through so there's just one little tail. If you have a tail that's too long, it's difficult to manage and tie. So we're going to pull that straight through, and then I'm going to take another bite, equal distance on the other side. I'm grabbing the tissue and elevating it, and then I'm going to throw the stitch equal distance. I'm going to pronate my arm, and I'm going to roll the needle out with the curvature of the needle and pull everything through. Now I'm going to do what's called an instrument tie here, where you wrap it once around. You go once around. I'm going to grab this, and to lock it properly, you pull opposite so that this goes down what we call square. Then I'm going to, if I need to lock it, I can take the tail to the other side, and you can see how that locked. Then I'm going to wrap it towards myself, grab the tail, and pull it opposite away. Then I'm going to roll towards the tail with one wrap, grab it, and bring it towards myself. And you can go back and forth several times. That's how you do a simple interrupted stitch. Now I'm going to cut this. Depending on where you are and what you're doing, you may leave some certain length here or not. I'm going to just leave a little bit of length there, and that's a simple interrupted stitch. I'm going to do one more at regular speed, the way that I normally do it, so that you can see what one looks like flowing without me talking. Let's lock that. So that's the simple interrupted stitch. Here's how you take out a simple interrupted suture. What you don't want to do is to lift the suture and cut beneath the knot. If you do that, you leave the lower loop in the patient. The proper way is to lift up, get under one limb. When I say one limb, there's a limb here. If I rotate this knot to the other side, there's another limb here, and you cut one limb and pull the stitch out. That way you get 100% of the suture. So this is a buried deep dermal suture where the knot is underneath because it's a dissolvable stitch. So we cut that right on the knot so that it's buried. You can't even see it. That's the point of that stitch. These aren't made to remove, but if you're going to remove it, you would peel back the edge of the skin, cut the whole stitch, and take out the knot. The next series of sutures are going to be called mattress sutures, horizontal and vertical. Horizontal signifies that the mattress suture bites are parallel to each other, and a vertical, they'll be aligned vertically. The point of these sutures are in areas of high tension, so over a joint where we really want to hold everything tight, it'll hold everything really snug and tight. And the other thing you're going to notice when I do this stitch, when I pull it tight, it's going to actually take the two layers or the two edges of the cut, and it's going to evert them and pinch them up. It's going to distribute all the tension to the deeper layers of the closure. So, horizontal mattress suture. I'm going to load it backwards. This is taken even with the other stitch, but next to it. You want equivalent bites coming out at the same level. So when we pull this tight, you're going to see the eversion of the skin edges. So that's the eversion. It's not locking. That's okay. So you can see how it bent the edges outward. Now this isn't perfect because it's not a real patient. All right, the removal of a horizontal mattress. What becomes important here, similar to the other stitch, is that you don't want to leave this limb or this limb underneath, because typically this is a permanent stitch. So the best way to remove these is to grab the loop on the opposite side of the knot, cut it, and pull the whole knot out so that you get both limbs of the stitch. Vertical mattress suture is also an everting suture, just like the horizontal. The vertical actually everts a little bit more than the horizontal, but the vertical mattress is going to be vertically oriented. So we're going to take a little bite and another little bite, and then we're going to come behind it and take a big bite, but just behind it. Wow, I went right through the thread. That is so hard to do. So that everts as well. Horizontal and vertical next to each other. So let's go over how to take these out. We know how to remove the horizontal by cutting that limb to get the whole thing out. For the vertical mattress, grab the knot, and just like before I said, don't cut both limbs. There's one limb here and one limb here. I'm gonna cut one limb of that knot only, if I can, and the whole thing should pull out. Next stitch is a simple running stitch, or the baseball whip stitch. And we might use this again in an area of high tension where we're going to take them out within a week or so. So you start at one end of the wound and do a simple interrupted, just like before. Oftentimes you'll cut this tail so it's a little shorter, but that stays behind. A simple running is we're just going to go in even bites across the whole way. And obviously these don't look as pretty to me as they do in the OR. It's hard to make them look symmetric and pretty. And then I have a tail right there. And the last stitch I'm going to do is a running locking. And the other one was just a simple running, but what I'm going to do here is I'm going to lock it, which means I'm going to come out inside of the loop like that, so it creates a lock. So I'm going to lay my loop this way, take my bite inside the loop. I'm going to grab my needle inside the big loop, and you can see the difference in the way that that one looks. It's locking. This is a very solid stitch for something that you do not want to come apart. So that is a locking stitch. That's the configuration. So we'll just cut this one and pull it, unravel it. It's a pretty cool looking stitch.